Hi, is the screen visible now?
Yes, sir. It's
Yes,
visible.
sir.
Yeah.
Yes,
So
sir.
very good evening to everyone, and I thank Dr. Gujral and Dr. Anita and his team for inviting, giving me a chance to interact with the students here. And that's what it sees. The topic here is about medical kidney disease, and many of you might not have had a chance to look at renal biopsy during your routine. So the basic idea of this talk would be to kind of sensitize you to certain patterns here, so that when you actually go down and see your slides, whenever you get a chance to see, you know some amount of stuff which will help you going further in your career, right? So, so this is the outline of just a verbal disclaimer. I do not have any conflicts of interest to declare here, and this is how the talk would go. So first, I will start with the sample collection fixated. So we'll just go from the basics and go to the basic laboratory processes where is stains used. Then we will kind of a touch upon the normal appearances regarding the histology, the ultrastructure, and then we'll just talk about a few patterns. So basically, renal pathology is a pattern-based study. So approach how you diagnose medical renal disease, just a primer kind of a thing, right? So, since we are talking about medical renal disease, it's a very interesting field which has developed. See, first it's histopathology. From there, you branch out into specialization. So, renal pathology itself has two branches. So, what I deal with and my colleagues deal with is medical renal disease. So, you can call it kind of a hyper specialization. So, we know nothing about tumors. So, there is a specific set of people who deal with tumors. So, we deal with only medical renal disease. So, what we are talking here today, anything about renal biopsy is a medical renal biopsy, which is performed for medical causes, just like proteinuria, hematuria, AKD analysis. And allograft biopsy is a different speciality in itself, which we will not be touching upon in this lecture. It's out of the purview, but it also falls into the domain of medical renal diseases, right? So we'll start with the sample collection here. So a lot of you would be interested in this because see, it's very important. Unlike many other branches of pathology, of course, it's important, but here the importance is far greater because everything eventually will depend on how you collect the sample. If you don't do it right at that point, you will lose a lot of information down, and you may not be able to make a correct diagnosis. So before we start about the sample collection, you would know that you should know what are the basically indications for medical renal disease. So there are basically four major classes of indications, clinical indications for which renal biopsies are performed, in which most common ones are proteinuria, of course. You must have heard about nephrotic syndrome and other things. Proteinuria is one of the major causes why renal biopsy is done. And that proteinuria usually is significant, usually more than 1 gram, and usually nephrotic range proteinuria, more than 3 grams. Then you have hematuria, and then you have AKI. So AKI is acute kidney injury. So what we used to call it AT and other things, they fall under the purview of AKI, acute kidney injury. And then you have a chronic smoldering disease, CKD. So sometimes to find the cause of CKD, you do a kidney biopsy. So these are the major causes which should be aware of why at all a renal biopsy is done. So just as a couple of things. So a native kidney biopsy is kidney is a retroperitoneal organ, right? Native kidney biopsy. So you make the patient lie on his stomach and then do the biopsy from behind. Whereas a transplanted kidney is usually done on the iliac fossa. So the patient lies prone in that. So these are things you should be aware of. Now, once a biopsy has been taken, so it's usually done by the nephrologist or by a radiologist under ultrasound. Most of the times under ultrasound guidance. So you do an ultrasound guidance, locate the kidneys, either the poles or wherever you want to take the biopsy from, and then the biopsy is taken. So when it comes to the pathologist, there are two things which can be done. Either this can be done on site or it can be done quickly in the lab. If the lab is located within the hospital, you can take a fresh biopsy, look at it under the dissecting microscope, and try to judge the adequacy of the biopsy. So once, if you are judging the adequacy of the biopsy right at the biopsy site and you feel that the biopsy is inadequate, you can then there request the nephrologist or the radiologist to take another course. So that's the idea of trying to judge the adequacy. So the adequacy here is in terms of number of glomeruli. So if you have an adequate number of glomeruli and adequate representation of cortex and medulla, you deem it to be satisfactory, right? So this is the idea of looking at it under dissection microscope and trying to judge whether the biopsy is adequate. You can do it this way, or you can even do it by a good hand lens, and you can see these glomeruli as small reddish structures which are denoted by the arrow here. Now, why so much of talk about sample collection? The reason being, renal biopsy interpretation is a multi-parametric analysis. So you don't go one step by one step. So now you have done LM, now you want to take another sample for IF. So everything you have to decide upfront, right? And since this multi-parametric analysis is required for a final diagnosis, you need to be careful about the sampling right at the start. So you need to take a core for light microscopy, just like you do for any other biopsy. You also need to take a sample for direct immunofluorescence. So these two are indispensable for diagnosis of medical renal disease. So you cannot say I can just diagnose renal diseases, medical diseases by looking at light microscopy. No, it's not possible. So at least LM and IF have to be done for each and every case. And wherever possible, electron microscopy should be added. So these are kind of three pillars of renal pathology or nephropathology: light microscopy, immunofluorescence, and electron microscopy. And all three have different sample requirements, different fixative requirements, and they need to be taken care of right at the time of taking the biopsy. So this is one. There are several ways you can triage the specimen when you are taking the biopsy, but this is the best. I like this particular way of doing it the best. This is from a very nice article which is referenced at the bottom of the slide. You can go and read it if you want later on. So if you are lucky to have two cores, you can divide it in the way it is shown in the picture. So you can take the smaller cores from the edges of both the cores and put it into EM 1 mm, and then you can take the larger cores for light microscopy and the smaller one of the remaining for immunofluorescence. So, and if you have a single core, you can do the same thing in a half manner. So you can take the edges for EM, the larger part for light microscopy, and the smaller part for immunofluorescence, so that you don't have to go in again and again. But the best is you take different cores for all the three specimens, but that's rarely possible because it's an invasive procedure, as you all know. So now coming to fixation. So now we have realized there are three different ways you have to take those samples, right? And all these three have different fixative requirements. So for light microscopy, just like the usual biopsies we take, you put it in buffered saline, buffered formalin. For EM, you need to prepare EM grade 3% brutal diet solution. So that vial also should be ready at the time of biopsy. And then usually for immunofluorescence, you don't require a fixative per se, but there are transport media, as you must have known, right? So Michel's is the most famous transport medium used. And if you put a biopsy in Michel's, it can hold at room temperature for almost about 24 to 36 hours. So you really don't need to care too much about it. But of course, if the temperature is high, 24 hours may become a bit too long. So it's ideal to transport it to the whatever lab you're doing within 24 hours. That's the ideal way of doing it. So basically, these are not fixative; these are transport medium, right? So for light microscopy, formalin; for immunofluorescence, Michel's or Zeus medium; and for electron microscopy, glutamine. So these are the three fixatives you should always remember. Now, as for light microscopy, as usual, as you must have known, you will be seeing most of the things in your during routine pathology training. So you do the same thing, but the difference comes when you start cutting the section. So renal biopsies are cut at very thin microns. So maximum thickness you can get of a renal biopsy for light microscopy is 3 microns. So usually they're cut at around 2.5 to 3 microns, and you have to take sequential ribbons. And every case you need to cut at least 30 to 45 sections so that you get a complete overview of the biopsy. It's almost like doing a CT scan, whole body CT scan from top to bottom. So we look at the biopsy in entirety so that we don't miss out anything from there. And another difference here is what are the stains which are called special in routine histopathology are actually routine in renal pathology. So you do a PAS stain, a silver stain, a Mason's trichome, and a Congo red for each and every biopsy, irrespective of what we are dealing with. So these are upfront done for each and every case, right? So this is just what I'll do in next few slides is just acquaint you to the appearances of renal biopsy in various stains. So this picture will go into your mind, and whenever you see the renal biopsy later on, you will be able to recall these pictures. So just you must be aware of this. H&E stain is the most general routine stain used, and it gives a good contrast and good information regarding the various compartments of the kidney. What PAS stain? The PAS is called it's the periodic acid Schiff stain. Right? It's a stain of the Schiff's family, and it has a peculiar property of staining the basement membranes in a magenta reddish color. So this is what is happening here. So you can see a magenta colored appearance of basement membranes here, even here the Bowman's capsule, which I'm annotating here. And these are the sclerosed glomeruli, which have been replaced by collagen, which is again staining red, right? So it gives a lot of contrast to the whole picture, and you can judge the basement membrane thickness, both of the tubules as well as the glomeruli. The slide. I apologize for this because the slide is not moving.
Alok, just double click on the slide. Double click on the slide, maybe.
Okay, perfect. Thank you, sir. So that's it. So we just saw about the PAS stain, and this is the Mason's trichome, right? So this is a low power view. What you can see here, the blue areas which you can see here are actually areas of fibrosis, and this is the particular reason why this stain is used. So it gives us a very good view of the overall fibrosis in the kidney. And mind you, fibrosis is one of the most important prognostic indicators in medical disease. More the fibrosis, less are the chances of that kidney surviving to a longer extent. So we don't want too much of blue empty in our biopsies if you looking at the patient's perspective. And another thing which MT also does is it highlights the immune complexes as red. If you want to look at it very carefully on a high power, you can see that many immune complexes will take up the red stain of the Mason's trichome. These are the two major indications of doing a Mason's trichome stain. And this is a silver methylene stain. You can look at it by the black color. What I have highlighted here is a glomerulus. Okay. And what I'm trying to show, this picture would again come back in one of the later slides. And what I want you to focus here is on the capillaries. So these capillaries are actually showing you tram tracking or double contouring here. I don't know whether you can see annotating and other things, but if you look carefully at these thread-like structures, many of them would show you double contours. And this is only possible when you stain it with silver. So if you don't stain it with silver, this reduplication of GBMs will not be visible clearly. And that's one part of it. And secondly, of course, in membranous GN, you need to look at the membrane texture alterations, spikes, and all those things. We'll come to that in a later slide, right? And of course, the last stain, Congo red, we do it for all the biopsies as a renal pathology center. Very well aware of the fact that sometimes amyloid deposits are so subtle that they might be missed on routine and other special stains. So doing a Congo red stain upfront on each and every biopsy, kidney biopsy, is a very good idea, right? So you can see this left side, you can see glomeruli with this, I don't know what color you call it, mahogany or whatever. And when you polarize it, it shines into a bright so-called apple green. Actually, there are shades of green and orange here, but it's called apple green, which is the classical color for amyloid birefringence under crossed polarized light. So this is all about the stains, and this is just a collage to tell you how glomerulus would look under different stains, which are highlighted, which are annotated here. So HAE, PAS, trichome, silver. So all these 4 stains, they are used routinely. So there is no special stain in kidney biopsy. Everything is routine. All special stains transform into routine stains in renal pathology. So this, what I'm trying to show you here is just so you need not bother too much about this. Don't go too much into detail. I have already told you what exactly those stains were doing to renal parenchyma and what information were you trying to achieve by doing so many stains on a kidney biopsy. So this is important. So HE gives you a general overview. Just a revision. PAS gives you basement membrane and mesangial matrix, which probably I missed during my earlier this thing. Trichrome gives you fibrosis, fibrin. Of course, when there is necrosis, the fibrin shines as red colored structures, fibrin and immune deposits. Silver gives you a nice view of the glomerular and tubular basement membranes and also mesangial matrix. Normally, mesangial matrix is silver stain positive, so that it will give you a blackish color. And when anything gets deposited there and loses its color, then we call it silver negative areas, which are indications for further investigations, right? And of course, Congo red, as we just saw, is the only stain which can actually detect amyloid. It's a gold standard kind of a thing for detecting amyloid deposits, right? So just a few slides now on bright field microscopy. This is the interesting part of renal pathology. So when you have, if at all you get a chance to set up a renal laboratory in your organization or institute, you will need to train your technicians specially to cut renal biopsies, because you need to cut a very long ribbon, almost 40 sections per case, and then you tick sequentially on the slides. So for each case, in our lab, for example, we follow that we take 8 slides, and 1, 2, 3 are HE, 4 is PAS, 5 is silvermethylamine, 6 is mesenteric, 7 we stain for Congo red, and 8 again we go back to PAS. So this is what the section we follow, so that we don't actually miss out on any compartment, right? Like I said earlier, it's like a CT scan of the kidney biopsy, top to bottom. Now coming to direct imaging. So I just told you about the multiparametric analysis in the initial slide. So we're done with the light microscopy part of it. Now coming to immunofluorescence. Remember, we had taken a sample in Michel's medium. Okay. So what do we do with that sample? So that sample is actually cut under microtome, just like you do for your frozen sections, the same microtome. Sections are taken on slide, and the idea here is to try and detect if there are any glomerular lesions. So glomerular immune deposits. So many of the glomerular diseases or renal diseases are immune mediated. And our idea is to detect what immune complexes or what immune mediation is there in this particular case. So that is why immunofluorescence has to be an integral part of each and every interpretation of the renal biopsy. So the common panel which should be used is of these 7 antibodies which I have highlighted in the yellow color. So IgA, IgG, IgM, C3, C1q, kappa, and lambda. So these you have to do for each and everything. The reason being, the IgG, IgGM represent the heavy chains. So the heavy chain part of the immune deposits can be detected by this. So you have an IgA nephropathy, you have an membranous nephropathy, whatever. So depending on the immune nature of that particular disease, you can diagnose the biopsy. Then we have complement components. So C3 is the junctional component and C1q is the late complement component. So you get an overview of the whole complement cascade by doing just these 2 stains, C3 and C1q. And then of course the corresponding light chains. So as you may be knowing, a lot of renal diseases are monoclonal in nature. So they either have a kappa light chain restriction or have a lambda light chain restriction. So unless you do a kappa lambda light chain in each and every case, you will miss those cases of light chain restrictions, which are very, very important because they actually uncover an underlying hematologic malignancy most of the time. So the appropriate treatment will not be instituted until and unless you take the first step in identifying correctly the light chain restriction, right? And rest of these are optional. If you have a good laboratory, you can play around with these and get more insight into pathogenesis. And we even now do IgG subclasses for all the cases. So that's a different domain altogether. But those are not done to be done routinely. The 7 which I have told are to be done routinely. And what we do here is these. If you have paid attention, what I have told you, it is called as a direct immunofluorescence, right? So why do we calling it direct? You must have read. So because what we are doing is directly on the tissue, we are applying these antibodies. So wherever there is an antigen or an immune complex, these antibodies will go and bind. And since these antibodies are tagged to a fluorophore, which is most commonly fluorescein isothiocyanate in renal biopsy. So FITC is the most common fluorescein conjugate we use, and this lights up green because its excitation spectrum forms into the green light. So this is just I'm just showing you for those who may not have seen, this is the cryostat on the left side. And on the right side, we have a dedicated fluorescence. So you need to have a fluorescence microscope. Either you can buy a dedicated fluorescence microscope, or you can get a fluorescence attachment in your already existing microscope. You can upgrade your microscope to look at immunofluorescence. As I just told you, the excitation spectrum of FITC is around 525 peaking, which is in the green. So what you visualize here is just like this in the image. So this is a nice capillary wall granular green colored staining for membranous glomerulopathy. We will come to that in a minute, right? And immunochemistry is everywhere in pathology, right? So it has become the mainstay, had become the mainstay for a very long time in oncopathology. And even in renal pathology, to detect immune complexes and various other things like viruses, we use immunohistochemistry far and wide. So every renal lab should have facility for immunohistochemistry. And these are the common antibodies which we use for IHC. So we need to have a C4D, which is more relevant in transplant pathology. We are not covering that today. But a lot of viruses like BK, the cytomegalovirus, the stains for amyloid like the SAA stain, the LEG2 stain, and the other newer diseases like DNA JP9 for fibrillary. So we need to have a good panel of IHC also backup to do a good practice in pathology. And what you see at the bottom of this, just make a note of this, but we'll come to this when we talk about membranous GN. So a whole lot of new antigens have been discovered for membranous GN, which need to be seen by respective antibodies. So you need to do an immunohistochemistry to be able to detect that antigen. So just showing you a couple of slides. So the left one on the top is a PLA2R. PLA2R is phospholiposis A2 receptor antibody, which is a very common component of the immune complexes in membranous glomerulopathy, right? And the bottom one shows you nuclear staining for BK virus. So a lot of transplant biopsies get infected by this horrible virus, and it literally eats up the renal allograft. So this is the only reliable way you can detect the BK virus nephropathy. Now the last part, remember we covered the two parts. Now we come to the transmission electron microscopy, the third pillar of renal pathology. Although this pillar is essential, but in a lot of cases you can do without it also, but it is always better that you do an ultrasexual examination of your renal biopsies. So what happens here, if you remember, we had taken the tissue for EM in glutaraldehyde, right? So it's processed in almost the same manner as we would process a routine biopsy, with some differences in processing, but eventually what happens, just like we embed our tissue in wax in routine microscopy, we embed the tissue here in a resin. So there is a basic difference, and the resins are usually araldite and various variants of araldite, and then you cut it under an ultramicrotome, right? So there are two ways we do it. First, we cut it under ultramicrotome, and then when we select the area, you cut very thin sections. So the thickness of the final sections for electron microscopy, the transmission electron microscopy, is only about 50 to 80 nanometers. You can imagine how thin the sections would be, because that is the only way you can actually allow the electrons to transmit through the biopsy specimen. So that is the idea of doing. And there are no specific stains per se for electron microscopy. These are chemicals which give a contrast to the whole picture. As you may have seen images, as we'll see in a moment's time, these images are shades of gray and black. So what these stains like granular acetate, lead citrate, and osmium tetroxide do is provide various shades of gray and black to the tissue, so that you can identify the various organs, right? So there is no colorful stain per se. It's just shades of gray and black because of these two or three chemicals which we use, and these are very toxic chemicals, as you must be knowing. Granular acetate, in the fact, is radioactive. So once you start using these chemicals in your laboratory, you will have to comply with the government radioactivity and BARC norms also. So that's another hindrance in doing electron microscopy, if you can call it that. Just showing you. So what I'm seeing here is, what we are seeing here is a resin block on the left side. So just like a paraffin block, this is the resin block on the left side, and on the right side you can see an ultramicrotome. So since the sections are so thin and small, they need to be done under microscopic guidance. So this particular microtome has a microscope attached to it. So you see under microscope and cut very small and thin sections. And in the interesting part of the lower images, this is actually a grid on which the sections are cut, right? So this is basically equivalent of the slide which we see under routine microscopy. And you can imagine this is being compared with the head of a matchstick. So it is so thin. So the usual size of these grids is, they're made of copper and various other alloys. 3 millimeters of width, and they are 20 micron in thickness. So you can imagine how fragile and small these EM slides, if you can call them, are. And that's where all the technical expertise comes in. So the person cutting and staining these has to be very, very adept at all those processes. And this is the electron microscope. It's a transmission electron microscope. So most of the times for biological systems, we rarely go more than 120 kV. So these are basically emitting electrons. So instead of light, we are using electrons as the source of light in transmission electron microscopy. And then since the wavelength is so small, you get to see a huge amount of resolution as well as magnitude. So that's the basic principle of doing transmission electron microscopy, right?